Good evening, and nice to see you, friends, here. It's the fourth time. I'm happy to open the fourth CLUE Working Group lecture. This time is a very new, very innovative talk by Mohit Bhandari. And a little bit before talking about Mohit Bhandari and his talk, let's talk very shortly about CLUE Working Group. So CLUE Working Group is a research group. We aim to deliver improvement in urology and other areas of medicine and surgery. To those people who don't know what is clinical epidemiology, it's something like on these slides. We don't necessarily have one focus on one disease, but our focus is our methods. We do observational research, surveys, randomized trials, meta-analysis, and guidelines. And for us, it's all about patient-important outcomes, collaboration, knowledge translation. And we are super happy to have Academy of Finland and Stigrid Juselius Foundation, as well as Helsinki University Hospital, to be our sponsors and supporters. We believe it's important to not only do research, but also do knowledge translation and have a societal impact on the work. And partly because of that, and also because it's quite fun, we are also having this CLUE Working Group lecture series, which you can find all these, as well as this lecture by Mohit Bhandari on Thursday. The other presentations you can already find on our YouTube channel, CLUE Working Group YouTube channel. So our first talk was by Alan Francis, the former DSM's chair, the former, which is called like a Bible of psychiatry. He was talking about what is normal and what is not normal. That's so far our most popular YouTube video with more than 2,000 views. Then Richard Schmidt, our former BMJ editor, was also giving a great talk about how to publish and how should we publish in future. Last year, Rita Redberg, the JAMA Internal Medicine editor-in-chief, was giving a talk on overdiagnosis and overtreatment. This time, we are having something new. I'm super happy to introduce Mohit Bhandari. Mohit is a professor of orthopedic surgery at McMaster University. He's a world leader in orthopedic surgery, but also other trial methodology overall. We have something in common. At least we share the same mentor. Gordon Guyot was his mentor back in the days and still is. And it was also mine. And if you think about randomized trials in surgery, you may think they typically have some dozens or maybe hundreds of patients, but there are some really large-scale randomized trials, and Mohit has led some of those. You don't see many randomized trials in surgery with more than 10,000 patients recruited, but he has led that kind of stuff, and he's really the best speaker I can imagine to have here today. So Mo, thank you very much for coming here to Helsinki and giving the talk. And anytime anyone can interrupt, Lauri will throw the catchpoke to you, and then you can say whatever you want. But hopefully, at least in the end, we will have a fruitful discussion. So welcome and big applause for Mohit Bhandari.
Well, thank you very much, Kari. And I'm going to spend a little bit of time with you talking about where I think surgical trials are, but broadly, research in general, and work with you through what I believe is this movement towards data analytics, this movement towards larger clinical trials. And at the end of the day, I've spent about 20, 25 years or so now, and I reflect back, and what I've learned the most is we have to be able to tell stories with data. This is really about trying to understand that. And the fundamental thing for us, and I'll think broadly, but when you are conducting research, you can't let other people tell your story. When we think about storytellers, great storytellers, those are the individuals who have ultimately been able to use some medium, some information, and be able to tell those stories. You can be a comedian and tell stories, or you can tell stories with ever saying a single word. But all of those are really functionally ways in which we've learned. So for me personally, probably in the last 5 years or so, I've really become aware of the importance of using information. And I used, for the last 20 some odd years, the randomized clinical trial as the key source of storytelling. And that is basically where we've moved. And if we can own the evidence, we can own the story. And we can see that in any possible way. You know, when we talk about whether it's politically or scientifically, the story is based on something, right? And that information. So if we can own that evidence, we then can begin telling the story. And fundamentally important, we don't let somebody else tell the story of our own area. This is Professor Gordon Guyatt. So Gordon Guyatt, many years ago, who's an avid cyclist actually, but many years ago said, you have to come up with a brand, you have to come up with a focus of what you're going to do. And back then, that focus was 2 words. Just think big. Now, when he told me this, I was in my 2nd year of orthopedics. I was starting a master's of epidemiology, or health research methodology, and my fundamental goal at that time was not this. I didn't understand this, right? What I understood was I need to complete my thesis, defend my thesis, and then we'll continue moving forward. But he continually promoted that one focus, which is you've got to think big. And by the way, when you've done something, ask yourself, could we have done something bigger? And at the end of the day, I hope you'll understand that this isn't as simple as just saying include more patients. Including more patients is really important. Getting big numbers is really important. If we look at what's happening now with big data, right? Big data has become the new oil, right? Data is the new oil. It is absolutely, he or she who owns that data has all power when we think about where we're moving. But this is basically a quick synopsis of the type of work that we've been doing in orthopedic surgery over the last few years. So I would say cumulatively, we've recruited about 50,000 patients into randomized trials. My very first trial with Professor Guyatt back in 1998 was 1,000 patients. And remember, back then, the definition of a large, simple trial was 1,000 patients. And that was based on the work of Sir Richard Peto and Professor Salim Yusuf, who were both a prominent biostatistician and a cardiologist, who had said, we've got to get more patients into studies, because then we can actually come up with the right answers. And I'll share with you why it's so dangerous to have small studies. But you can see over time, we've gone from 1,000, and in 2017, we had 10,000. But this is the storyline, right? Fundamentally, there's going to be 4 parts, and I will walk you through each of those as we go through it. But I would say, all of us, whatever our backgrounds may be, some may be in surgery, some may not be, some may be researchers, some may be students, whatever that case may be, we have a vision when you enter healthcare and enter healthcare practice, whether you're allied or you're primarily involved in managing patients, that you want to use evidence and you want to make decisions based on some sort of rational decision-making process that includes high-quality data. But then we get into the statement of, what is EBM? And I'm not here to give you definitions of EBM. We've been talking about EBM for decades, but I will tell you that we get caught up in the detail, study power, whether it's an RCT, whether it's sample size, whether it's confidence intervals. And I put all that away, and I would say, think of it in my mind simply as signal. I'm trying to get to signal. And what we're trying to do as a group is together figure out where the signal is. But the challenge we all have, we always have that one singular challenge. This, noise. And so that is the battle we face with every question, with every problem, is how do we get to signal? And what does signal represent? Well, evidence-based medicine is unlikely going away, and it was unlikely going away at the time that the British Medical Journal also ranked it atop some of the greatest medical discoveries in the past 166 years. So we have no choice, or had no choice, but to learn the language, right? It was a completely new language. Right? I happened to be at McMaster University when Professor Guyatt, back in 1990, coined the term. And he said at that time, we want students to come to McMaster University, and we want you to come because we're going to teach you this new paradigm called evidence-based medicine. And by the way, we call that an attitude of enlightened skepticism, which means you shouldn't just believe someone on the podium talking to you and telling you the way it is. You should be skeptical about what you read and what you hear and what you see. However, you have to be enlightened. You have to learn the new language. You have to understand for yourself what it means to look at information and look at evidence. Now, 10 years, 10,000 hours, and I would put forth, if you haven't read some of Gladwell's work, it's an interesting read. He's an interesting writer, but even his work is somewhat of an underestimate. They say it takes 10,000 hours or 10 years to become an expert. So that would have said that roughly 1990, when evidence-based practice was coined by Professor Guyot at McMaster University, it would take about 10 years for those group of individuals to become fairly expert. New estimates suggest it's about 25,000 hours, or probably double the overall amount of time. But we started in orthopedics in 2000 with a book called Evidence-Based Orthopedics, and I was quite frankly laughed at the time we were proposing it back in 1990, would have been 1998, and they said it'll be a very small book. There's no evidence in surgery, there's no data, and it'll be a very, very small book. Well, I will tell you that it turned out to be a very large book, and we're having our second edition come out now. It's been 20 years, so I think we're due for a second edition. But here's the other point. Whatever journals you read, right, information is coming at us at such a rapid pace that decision-making in the past was we could rely on a single academic journal for the majority of our academic knowledge. Impossible in 2019 and beyond. So what we've done, and I suspect we're seeing that in all areas, in medicine and in healthcare, where we're seeing aggregators. And the reason is that if you look at a single orthopedic journal as an example, and I suspect this is not uniquely different for other journals in other areas, if you focus on even the highest ranked orthopedic journal, you still miss 90% of the highest quality data that comes out every single month. So clearly, you can't be reliant on a single source. So we need to have other sources. So these sorts of things are coming out, and we're getting more and more and more information, so we have to find ways in which we can pre-appraise it and get it out. But at the end of the day, all we're trying to do, if you're on the front line, is make better decisions. If you're a researcher, you're trying to help others make better decisions. So, I always ask this question to our trainees, and I also ask it to our consultants. I say, what's the most important attribute that you want to have if you want to go from good to great or great to exceptional? If you're competent in both, what do you want to get better at? Now, usually the junior trainees will say, I want to get good at this skill. I want to learn how to do this procedure, and I want to get really strong in this. The more experienced colleagues who have been doing this for 20 years say, it's absolutely about the decisions we make. And it unequivocally, when we look over time, decision-making is the differentiator. So if we can make better decisions, we can ultimately improve, our ability to help others. So this is a truth. I have not been able to identify anyone who can come up with something contrary to this. A poor decision, perfectly executed, will always result in a bad outcome. So the most skilled of surgeons making bad decisions time after time will have bad outcomes. It just happens. And so I think in many ways we have to be thinking about this. And when we think about this, we can look at, you can say you can take a broken hip. You can fix it with screws. It can look very good, and then the hip can fall apart. And you'd say, well, what was the problem? Was it compliance of the patient? Not at all. It was the wrong decision. The decision, based on evidence, may have had a different type of implant to be done or a different approach. And while we're talking about the expertise, evidence-based practice always says, the problem with evidence-based practices is that, we don't get to use our own experience, our own expertise, and sometimes we just don't have evidence to help us. So the concept of expertise is fundamental and central to evidence-based practice. But in the hierarchy of evidence, and some of you may have seen this pyramid, we talk about opinion as being the basis of everything else, right? It's the basis of that evidence ladder. And so in this particular case, level 5 all the way up to what I focused on, which is a randomized clinical trial. But that doesn't mean that opinion is bad. It just means that if there are other data points that it can inform opinion, we should be thinking about that. And if you look at the tech industry, they're very, very, very negative on experts, generally speaking. Why? Because they think of effects that sometimes you can have overconfidence when you know little about an area, and therefore the real risk of a so-called expert can be that they can make big, big errors. And actually, if you look at this effect, and Dunning-Kruger actually won the Nobel Prize in psychology for this particular effect, which is basically the concept of the less you know, the more confident you typically are. And as you get more experienced and expert in a particular domain, you start to realize, you know what, I know what I don't know, and therefore you become a little less confident and a bit more cautious. So therefore, the real experts who are cautious would say, I need to take, if it's a surgeon, I want to take this expertise that I have, but I want to make sure that I continually learn and continually start to apply best available research evidence. And that gets to the point of, okay, well, what do we use? So how do we come to better decisions? What are the points that we can use? And the central hypothesis for me right now, has been for the last 10 years, that small studies have a very big risk. No matter how well we conduct them, they have a big risk. And let me walk you through what that is. Everyone says, oh, the elephant in the room is the size of your study. When you look at a study in a journal, you look at the sample size, and you immediately make some judgment about whether you'll believe it or not. A study of 20,000 patients versus a study of 10. We have a very different belief just because of the number there, right? And we're also very concerned about, well, how many patients do we need in our study to make it accurate? But I will put forth to you that one of the most provocative hypotheses, and one of Professor Ioannidis' most highly cited papers, published now, you can see, well over a decade ago, suggests that most published research findings are false. Yes, 3 central core hypotheses around that. Hot topics, conflicts of interest, and central small studies. So let's dig deeper into why is a small study going to lead us to the wrong answer more often than not. What's the size of an average surgical trial? An average study. Yell one out. Give me a number. 150. Okay. Anyone want to go lower or higher than that? Give me one more estimate. 50. Okay. So right in the middle, roughly, right? Under 100 patients is the average surgical trial. Average. And I've used this slide now for about 10 years. I check, and there's some outliers, but generally, when we look at the small and the large, it kind of works itself out to roughly the median number of patients in a study is about 90. Now, ask yourself this. We are now trying to convince ourselves that when we see, even in our top journals, a study that says 45 patients treated this way versus a control had a better outcome. Therefore, everyone in the world should apply this new technology or this new treatment or this new approach. And most people would say, nah, we're not going to apply it. And then we say, well, it's in the top journal. It's a high-quality study. People are not necessarily applying this information. And why is that? And this is not an orthopedic phenomenon. This is a surgical phenomenon. So if we look at surgical trials, 50% likely are just too small. So when they don't find a difference, is there a difference? We don't know. But they should at least be 10 times bigger. So when we see 90 patients in a study, probably, at minimum, it probably should have been 900. And we'll walk through some of that. Look at this one. 12,000 patients published in clearly one of the top 3 medical journals, The Lancet, talking about aspirin risk. They predicted that they were going to see an outcome event rate of 15%. But here's the problem. When you actually get into studies and you make estimates of what you think you're going to see, you don't always see that. So they actually found in this case, cardiovascular disease event rate of 4%, which immediately made this 12,000 multi-million-dollar study underpowered. So they weren't able to come up with a clear answer to a problem after spending multiple years and multiple millions of dollars. And this is the challenge we face. It is real, it's happening, and it's happening at the highest level. Now you would say, and we would say, my goodness, 12,000 patients, surely it's enough. But here's the problem we always face. When we decide to plan a study, we say to ourselves, okay, let's look at the prior data to inform how big our study should be. I put forth, having done this now for many, many years, we have always been wrong when we look at the prior data. And the hardest part about it is that until you get a large number of patients, you really don't have a good sense of really what that true, quote, event rate is. But let's go back to the very first study. I showed you that very first study I did back in 1998. So back in 1998, we had a study that looked at fractures of the tibia. And if we had stopped at 50 patients, just at 50 patients, we would have concluded in this that there are two different types of treatments. One is called an unreamed nail and a reamed nail. If you're not in orthopedics, not to worry. It's just basically make the assumption here that in this case, with 50 patients, the unreamed nail to treat this the rod that would have been used would have been prevalent, right? Or it would have been the story we would have talked about. It looked as though it favored that, right? In this particular case. And then what we would have said is, oh, you know what? If we just had more patients, we have this thing called a 95% confidence interval. And that 95% confidence interval tells us that the truth, that little black box in the center, which is the result of the study, could be anywhere from one side all the way through to the other side 95% of the time. So we don't know really where it is, but we often assume that it's probably more likely going to favor the unreamed nail, because as we get more patients, the confidence interval becomes more narrow. But here's what happened in reality. We recruited a few more patients, and at the end of the day, the truth was on the complete extreme of where we would have thought it would have been when we only had 50 patients. So we would have completely been fooled into thinking the unreamed nail is trending to be the better treatment, when in fact the reamed nail, after about 1,000 patients, became the treatment that was, in this case, significantly better for the treatment of these particular problems. And then I thought, okay, well, this is just a one-off, right? We went to our second trial, a very simple trial in very complex injuries that have broken bones with skin, which the skin is also torn, so it's called an open fracture, and they have a high risk of contamination and infection. So we thought, you know what? All we have to do is do a randomized trial in these complex patients and add soap. Soap would be logical to clean the wound, and maybe soap is the simple, frugal innovation that will reduce infections in this population. And in fact, in a 100-patient pilot, what did we find? We found, in fact, that soap suggestedly looked like it had fewer complications. We also looked at how you irrigate, the wound to clean it, whether you use high pressures with a motorized pressure irrigator or low pressures just by pouring it in onto the wound. And we suggested that low pressure was also better. At that time, a lot of the colleagues said, okay, done. We've had the answer. Let's go talk about it. Let's get on the podium. Let's travel the world, and let's tell the world everyone should use soap and everyone should use low pressure irrigation. But because we had learned from Sprint, we said, maybe we should wait. Maybe we should just simply wait and redo this and do it properly. So we had powered the study to be a lot bigger than 100 patients. In fact, we had powered the study to be 2,300 patients. And if you look at this, the first line talks about the pilot, right? The pilot, in this case, says, yep, low pressure lavage looks like it's trending to better. Our first 250 patients in the large study had the exact same finding, so it's confirming it. Recruit more patients, and what do we end up with? No difference. But even more problematic was the other side, the soap. It took us 1,500 patients before we were able to determine that soap was not helpful, it was harmful. Putting soap in a wound actually led to more complications and more problems for patients. We would have gone and promoted this had we stopped at our 100-patient pilot. And that led us to say, okay, we really have to be thinking about getting the most patients we can get into a study because of this concern that we are not ultimately getting to the answers until we're well above 1,000 patients. At that point, I met Dr. P.J. Devereux, who works at McMaster University. He's a cardiologist and fundamentally has been shaping the way we think about perioperative medicine. He brought up this concept of fragility, and he said, I don't even think it's about the number of patients we enroll, not at all. It's about the number of outcome events and how studies are fragile. So I said, well, explain this to me. He said, okay, let's go over an example together. And we went over an example. We used an orthopedic example because it was one that would be fairly straightforward to share, and I'll share this example with you. This is a study that had 450 patients, and what they did is they said, okay, let's look at these complex broken bones with open wounds, and let's treat them with a biological treatment. And that biological treatment is aimed to reduce the risk of having a reoperation at 1 year. And here's what they found. Very simple. They found that this new technique, new biologic, reduced the risk by over 59%. And you can see 12 patients had a reoperation in the treatment group and 29 in the control group. And there is the p-value. So there you go. This was then taken to the FDA, Food and Drug Administration. It was approved for use in that group, and they were able to get funded, right? And they were able to get it into use, and appropriately so. He said, now take a look at the number of outcome events. There were a total, in this case, of 41 reoperations. Then he said, let's do a thought experiment. That's what they found. Let's say we did that exact same study here, Helsinki. Let's say we got a number of centers together and we repeated it. Would we be shocked if we saw something that said this? 15 patients had a reoperation in the treatment group and maybe 26, a few events, a few reoperations go from one to the other. Totally reasonable. But here's the point he makes. With just 3 outcome events going from one side to another, this goes from a positive study that was approved by the Food and Drug Administration to a negative study that would have never been approved, and this would have never been allowed to be put in patients because of the risk or the lack of efficacy and also the cost. Now, you have to remember that putting this particular product into a patient was costing the system about $10,000 US per application. So it's a serious amount. Now, they repeated that study not that long after it was done, maybe a year and a half after. Same total number of outcome events, 44. And if you look now, no difference. So it actually was, in its own experiment, proof that this p-value that he called fragile, with just a few events going one way or the other, actually happens. In fact, because of that, this BMP2 is not used in the treatment of open fractures, at least in the early phase. We don't use it anymore for that indication. So it makes you think, wow, this was a well-designed study, 450 patients, well-funded, multiple countries, multiple centers, and led to a positive findings. That was literally reversed a year after by another study that came out and said it doesn't work. So how big is big enough? And that becomes the challenge. And this is, again, not just an orthopedic problem. Annals of Surgery is a high-impact journal. And if you look at this particular study, published in 2015, and this looks at barium impaction therapy for colonic bleeding, but, take a look at what they found. 15 total bleeding events. They said, oh, if you do this barium impaction, it reduces the risk by 66%, therefore everyone should get it. Now, I'm sure you can guess how many events it would take from one side to another to make this a completely negative study. And if you're thinking 1, you're correct. A single event going from one side to the other makes this a negative study. Once again, it's published as a strongly positive study. It's promoted as a positive study. Surgeons and sites will change practice, likely because it's a high-impact journal based on this study, and a single event would make this non-significant. And that is the challenge that we face. So as Dr. Devereaux says, well, it takes a globe, right? It takes a globe to answer a research question. So we have to do more, and we've got to figure out ways. And this has been the belief system that I have been working with, is how do we get more people engaged in research so we can answer questions together rather than have smaller studies that risk these sorts of challenges. This is a picture that I've taken from hotel rooms. Anyone recognize that city? Well, would you believe it's just the top is California and the bottom is Japan? People say, well, you can't do research around the world because we're so different. Well, if you look at that cityscape, you really can't tell the difference between some of these cities. So when we go global, it's actually a good thing. we can really get more and more people. If you take just cross-sections of populations around the world, fundamentally, we all begin to look the same. And I think even more importantly is the people in Kampala or the people in Tokyo generally have the same, hopes and dreams as anybody else. They have different circumstances, but you want to live in health, you want to have food, you want to have shelter as a very basic, and you want to have, some degree of satisfaction, happiness. That is a global phenomenon. So if we can find questions that really help us answer those bigger, simpler questions, we should do that. So I have changed the way I think about research in the last 5 years. So now when we ask a question, we say, okay, who's this going to be significant for? Is this question we're asking significant for everyone? That's the ideal. You try to get to that ideal. In doing this research, are we going to be able to connect more people around the world? Is this going to be of interest to lots of places rather than just our local area? In doing so, are we going to get more people engaged in research? And if we do that, that's a positive, right? That's a completely positive. And ultimately, this is the ultimate goal. Will this question and this work we spend ultimately lead to the well-being of, quote, all people? Now, it's very difficult to meet all these standards, but at least we should be trying, and that's all I say. We should be trying to hit these standards. So what does that mean in 2019? Well, more countries, more centers, and I'll say surgeons, but more investigators, the team, if you think broadly about any type of question, and we need more patients. But that'll happen. If you get more countries, you get more centers, you will have more patients involved and engaged in the questions we ask. But here's the point. When you start thinking globally and thinking, quote, bigger, your ideas, just by nature, get simpler. And in fact, by necessity, we only can really solve the fundamental problems. So if you're thinking about robotics in surgery, that is going to unlikely be one that is going to be relevant in mainland China, in India in some places, and all throughout some of the African countries. So those kind of questions, while very important for innovation in developed nations, don't necessarily, are going to be accessible to all people. So we have to think about how we do this. But we can talk about it, but we have to actually start acting on it. And here's the point, right? When you say, well, we'd like to do something very global, other people will say, well, you just can't do this, right? You can't do it. But what they're really telling you is, well, I can't do it, and therefore I'm pretty sure you can't do it. And then your response to that should be, you're probably right. I can't do it, but you know what? We can. And by one person at a time, we add more people. And you have these discussions with individuals to bring them on board. So I'll give you an example. This is a paper that was on hip fractures, but looked at different treatments for hip fractures. How do we optimally treat hip fractures? 2 different surgical approaches. Millions of dollars were invested in this study, many, many years, and many hundreds of investigators were involved, and many thousand patients were involved, recruited. At the end of the day, when I look back at my own criteria, I'm not sure that this was the right question to have asked, having said it all and done it all. I think a better question would be a question that would engage more people, and quite fundamentally is a simpler question, hard to do, harder to operationalize, but a simpler fundamental question is, fix the fracture however you fix the fracture. Get the patient to the operating room as quick as you possibly can. And is timing much more important? So this is now close to its full enrollment of 3,000 patients. But look at the number of countries we engaged. We've never engaged this number of countries. This is a study that has been led also by Dr. P.J. Devereaux. So he's been thinking very carefully about the perioperative events and timing. Maybe we should be doing that. And so you see the complete flip of question. Maybe the better question to ask is, treat it however you want. And maybe the type of treatments we do are important, but they may not be the big differentiators in health outcome. And maybe in this case, it's access to timely care. As you learned, we got broader by asking a pretty simple question. Does soap work in open wounds? And we learned, quite frankly, that it's actually quite dangerous in open wounds, rather than the opposite of what you would have assumed that it's going to be good for us. And then we went to another project, which we called Enormous, which we have now recruited about 35,000 patients for. This is a simple, fundamental question, which is in low, middle-income countries around the world, what are the predictors of 30-day mortality and major morbidity following road traffic accidents and fractures? Just fractures. The Decade of Road Traffic Safety said that we're going to try to reduce fractures and reduce deaths by 1 million patients, by 1 million over the decade. The challenge here is though that patients still get into accidents, and accidents still lead to trauma and suffering. And so can we manage, what do we do for those individuals who still have these injuries? And we're trying to learn about that. So while I've been a strong proponent of randomized clinical trials, I can tell you that in this particular case, we don't know what randomized trial to do. We don't know what treatment to offer. So the first thing we should do is figure out what factors are predictive of these outcomes, and then say, can we modify any of these, and then design studies. But here's the point I make. We were able to recruit these larger numbers of patients largely because we worked with numerous investigators, hundreds across many, many continents, to ask a fundamental, simple question that was important to them. So it mattered. And by mattering, we were able to get more and more engagement. Now I'm going to switch a little bit to talk to you a little bit about, well, great. So hopefully I've been able to at least give you some thoughts around, well, we need to be going bigger. And bigger is thinking about how do we get this collaborative going and how do we think that way. But it is not that easy. And quite frankly, when people ask me all the time, they say, okay, for 2019, what's your question? What are you doing next? What are you doing next? I get asked that. That's the biggest question. What's the big question in surgery that we have to figure out? Or what's the big question, in my case, in orthopedics, that we have to figure out? And then the first thing that comes to mind is that we need to identify individuals in institutions. Institutions are going to, we always, in the US and North America, we think, it's institution. McMaster University is in competition with Toronto, is in competition with the US, Mayo clinics, et cetera, and then everyone has their, quote, silos. Those have to be broken down, right? It's the individuals that we have to engage, and we have to work together to figure out what those big questions are. And here's the truth about this whole concept of institutions. Any institution around the world likely will have a complete cultural shift if about 3 individuals leave it in a particular department or a particular area. Because generally speaking, based on the power log distribution, which researchers, performers, athletes, all these sorts of individuals follow that, not the normal distribution. They follow the power log distribution or the long tail, which means there's a small number of hyper performers, generally speaking, that are very, very critical to the culture of a particular space. So our job is to say, well, your loyalty when we're doing programs and collaborations are to people, not to institutions. People are an institution, but if those 3 people or 4 people leave an institution and go somewhere else, it's a different institution now. So we focus a lot on team building and relationship building with individuals, so wherever they may go, and we build strong, strong allies over time. But what I have learned is that those individuals and those groups and those focus areas of research that have been able to sustain it decade after decade after decade have had 3 real characteristics. These are individuals or teams that somehow are able to anticipate change. They know that what got them here won't get them there, and more importantly, they have a general sense of where the field is going, and they know, because a randomized trial takes, a big one, takes a decade, easily a decade. You might be able to get it done in under that, but the planning and the final publication is easily 10 years. You have to be able to have a sense, is this question going to sustain for 10 years, and is it going to be relevant when it's done? That's the key. They seem to be able to have very, very diverse networks, And so when learning from them, I've been thinking, how do we get interaction with people we normally wouldn't interact with? And how do we build that? And finally, and this is the hardest one, you have to be willing to change. So if your research program started 20 years ago with one belief, if there's monumental evidence contrary now to that hypothesis that you may have held, you have to change, you have to pivot. So you have to have the courage to abandon all the practices that you thought were correct and that ultimately led you to prior success. You have to do that, because we often see that as also a big challenge for us. This is our academic division day at McMaster University. We had the editor of a couple of journals. So the Journal of Bone and Joint Surgery is the orthopedic high-impact journal. And we were chatting a little bit about leadership and about what it takes, because these individuals, in many ways were for many trainees, were saying, well, this is what I want to be in my field. I want to ultimately end up and make an impact. I want to be, respected for what I do. I want to make change. I want to be able to help people make better decisions, et cetera, et cetera. And surprisingly, when you ask them, what does success mean to you? And how do you get there? He said, Professor Einhorn from Boston University said, to me, success is better defined in terms of making a positive impact in the lives of others and achieving happiness and fulfillment in one's life. So he became very focused on, well, if I'm going to do well for others, I have to do well for myself. Professor Swinkowski said, collaboration, 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 right? So our community, meaning it's not just a single siloed center, it's a community. And as we grow in this community, that's how we're going to make big, big change. So he focused on this concept of community. But at the end of the day, Nobel laureates will say, when asked, tell us about your great success. Tell us about your great success. In fact, rarely are they talking about their success. They're talking about the fact that science is failure. And you have to be ready to fail. And it's what you do with that failure that allows you to move forward. In fact, Professor Lefkowitz from Duke University says, if you're asking big questions, if you're asking really, really big questions, you have to be ready to fail. You have to be ready to fail. And so these series of failures, he says thousands of them, allowed him to make incremental shifts in learning that ultimately garnered him a Nobel Prize in 2012. So here's the point. When I look introspectively, every year it's, okay, I have to overcome this courage to, to overcome the fear that we have. And here's the point. Every trial that we have conducted over the last 2 decades has succeeded despite a number of near fatal failures. And in fact, I can tell you there were moments, and I have every one of them, where I thought, okay, this is the moment that this trial ends. And it's through those processes that you work forward. This is the press release that went out in 2017 late that said, $14 million for this program. There's going to be 10,000 patients. And these 2 bright young investigators, Gerard Sloboshan and Sheila Sprague, you can see are smiling in this picture. Right? They see the future. This is the big trial they're going to run. And I am a little bit more cautious. I'm thinking, I know exactly where this is headed. And I know we're going to have some really tough goes ahead. And my stomach has this pit in my stomach where I'm thinking, okay, they don't understand how bad it's going to get, and it's going to get difficult. But we have to have the optimism we can do it together. So here we are in 2017, and Gerard Sloboshan said, Mo, would you be willing to speak to the group and talk about why we need these big trials? And here we are again, and I'm speaking about it. But, against an audience just like yourself, we're thinking about where are we going to go with this. And, this is going to be an exciting journey. But at the same point in time, I'm also thinking, I remember the enrollment of the last hip fracture trial of faith. The blue line is where we want it to be. The pink line is where we were. And I was faced with having to have those difficult discussions with our steering committee, in which they said all the time, they said, hey, you know what? Give the money back. Finish it. The study's over. Of course, we weren't going to do that. But we said we had to have a solution, because we can't go at this pace. And usually when difficult times happen and real challenges happen, what I've always found is we come together. And we come together and we get it done. And that's exactly what happened. We were able to come together and get it done and ultimately get this done. But I have thought about this. Why did we fail? Why did we have these big challenges? One is studies get too complicated too fast. And we just have to take a step back and say, do we need all this information? Do we need to make it this complex? Is there a simpler question we could be asking? Do we have the right people? First of all, am I the right person to lead it? And I have to get my ego out of the way. Am I the right person to lead it? And sometimes I'm just not the right person to lead it. I need to get somebody else involved, and maybe they should lead it and let me support them. Or at least we should find partners. We have to make sure we have a collective expertise. That happens a lot. And every time we've had big challenges, we've just been missing that component. Do we actually have enough infrastructure and people and funding to start? It's critically important to have that. And at the end of it, gets this other part. Do we actually have the grit? That feeling where can we stick it out? In hard times, can we stick it out? It's nice to have funding early on, and to have the big, excitement of a study, but, third and fourth and fifth year, you have to continue to maintain effort to get that study done. And at the end of the day, sometimes we just didn't have creative solutions to problems. Just didn't have it. And the question is, we got so caught up in the trees, we couldn't see the bigger picture of the forest. And that was it. So I highlighted that because for me in 2019, I was with a colleague of mine, and we're here in Nepal. This was early in the year, early last year. And I said, what's next? What are we going to do? What is the big plan? And when you're looking out and you're seeing, this amazing, amazing visuals of where you are, you're at 10,000 some odd feet, you have moments of clarity, right? True moments of clarity where you say, okay, what is going to happen? And the truth is, I don't know what the next question is going to be. But I do know that where my focus is going to be. And I'll share with you a little bit about how the last several months has gone for me. I've realized that getting caught up in just doing the day-to-day work that I do, and I suspect many of you are equally involved in the day-to-day work, whether you're studying, whether you're doing research, whether you're working in direct patient care, whatever that may be, you get caught up in that and you think more of it and more of it and more of it is going to make me better. I think the realization that I've had is more of it won't make you better. You've got to get perspective. You've got to leave that for a second. You've got to figure out the 20%, the complementary skill sets that allow you to have a much more creative approach to the work you do. And so the 20% of the things that I do give me 80% of the satisfaction. And I suspect if you make a list of the things you love to do, there's a small list, but they generally lead to the majority of your satisfaction during your day or your week. So I said, I'm going to focus on that, and I'm going to really focus on that, so much to the point where people are going to say, are you working anymore? Because it seems that way, that you're doing all these other things. But that's not the case. The case is that you're using that to actually come back and have what we would call a breakthrough moment to help you go on to the next level. So here's the pledge that I have in 2019. If you look at it shortly, you'll say, well, this has nothing to do with research. But I put forth it has everything to do with research. So the first thing is, just try new things. Last 4 months, just try new things and have a mindset of just getting much more creative than I have been. Going back to hobbies that from childhood and reinvesting in that time. Enjoy what you do to the extent that you can do it. If it's not enjoyable, limit the extent that you can do it. Now, it doesn't always work depending on where you are in life, but I have the privilege that I can control some of that, so I will do that. Invest more time in these complementary skill sets and actually embrace failure. Actually go into failure or experiments, and I'll explain to you what I mean, and say at the end of the day, no matter where we've come in our program, this last big study, we can reinvent it for 2019 forward and come up with a different model, a different plan. So we've been doing all kinds of these sorts of experiments. But, people have said to me, well, is this really going to lead you to a better, more successful research career? And there's interesting studies that have come out, and this came out many, many years ago. You can see in 1993 in the Creativity Research Journal. But they looked at individuals who were they would call highly successful scientists, many of whom went on to win Nobel Prizes. So they followed them forward, but they were identified as high potential scientists, but they followed them over time. And then they started to understand what did they do. And the thing that they identified, one of the key factors was they have a diversity. They're not just focused on one area, they're actually dabbling in many areas. And because they dabble in this area, it gives them perspective about this, and that allows them to have these periods where they have breakthrough moments. And so the thing I've learned from that was, well, we've got to diversify the things that we do if we want to ultimately make, bigger impacts. In fact, they also put here successful scientists have highly integrated networks of enterprise. Basically what they mean is you're doing lots of things, but you're doing things that actually, in some meaningful way, complement each other that allow you then to move forward. So, in the last several months, trying to do it for myself, but also for our graduate students. So these are all PhD students. We decided to do a failure experiment. They didn't know it was going to be a failure. I almost invariably knew this was going to be a failure experiment because we decided to climb a 12,000-foot mountain in a day and try to get up and down it with no prior experience of mountain climbing, with a guide. And the guide said, I don't think you can do it. And we said, well, we do it. You go, you sure you want to pay? Because you're not going to be able to do this. You're going to have to pay for it. I said, yeah, we'll do it. No problem. And we all went up, and we stopped halfway, and we popped a champagne. And I thought, okay, everyone's going to be upset because we didn't do it. We failed. Like, it was an absolute fail. We were nowhere close to the summit. And one of the PhD students at that point said, well, I get it. It wasn't even about reaching the summit. We had to have the goal, right? You set the goal that we're going to get there. You don't get there, okay. But they had the same elation of having summited a 12,000-footer than having gone halfway. And so we did it again. So I said, I'm going to try something else. I'm going to pick something that I have no skill set in and no transferable skill set in. So I've never skied, never. And 3 months ago I said, you know what? I'm going to pick it up. And someone said, well, become a skier. Skier generally is easier to learn, harder to become an expert in, but you'll be skiing day one after you get an hour or two on the slopes. Simple skills. They said, don't do snowboarding because it's really tough early on. It's going to be difficult. And you're going to, quote, they said, catch an edge. It's going to really hurt. That's what they said. I said, okay. I said, I'm going to do snowboarding. They said, you're crazy. You shouldn't do it. You're going to get hurt, and it's not good for you. I said, that's fine. Anyone here ski or snowboard, I presume you're relating to this advice. So I said, irrespective of that. So what I did do is I said, okay, this is going to put me into a situation I haven't been in a long time. Because, some would look at the work we were doing and say, oh, well, how can you understand failure? You've randomized 50,000 patients, you've raised, $40, $50 million, and you continue to have all these, quote, academic-based successes. So, how can you keep talking about learn from failure? And I keep saying, well, every part of this is about failure. But I went into a point where it was a couple of things were going to happen. One is I have to rely on students, the graduate students who work with me all the time, and they were going to become, quite frankly, the teachers, and I was going to become the student. So I was going to get really into that mindset. The second thing is I recorded and I tracked every hour on the slopes, my confidence level from a scale of 1 to 100, knowledge, skill, and then the learning. And I went through it, and you can see the blue line. And the blue line takes a dip at one fundamental point. And that's the point at which you have that critical moment where you think, done. I have no interest in doing this anymore. In fact, that's probably where I perceived the majority of my predecessors who gave up snowboarding, gave it up at that hard fall. And that was the fall where I understand what it means now. That's right there, that picture, because I recorded everything. And it was a wipeout, and my head went back, hit the snow on hard packed, and your head is ringing, your back is sore, and you're thinking, this is crazy. This is who's doing this, right? I'm not getting up after this. But here's the fundamental thing that I learned. Was literally 5 hours after that, I had my breakthrough. If I had quit right there, I was so close to my breakthrough. Now, breakthrough is relative. What a breakthrough was? Being able to do a bunny hill without wiping out, being able to do what's called the toe edge, as you know, and then the heel edge, and being able to get down safely and be able to control direction and speed. That was it. So for a seasoned snowboarder, well, that's just a beginner, right? But for someone who's moved forward, it's a major, major accomplishment. So it gave me a ton of new perspective. And you'd say, well, how does this apply back to your research? Well, it has everything to do with research, because I had to absolutely rely on people that normally are relying on me. I absolutely had to be able to, move forward when things look, against your own better judgment to keep pushing forward. And then you have that moment where even a small, relatively objective small win is a massive breakthrough. And those sorts of things have been particularly helpful. And the thing is, when we look at the university environment, when we look at what's happening with kids all the way up, I have a little 11-year-old girl, we are teaching non-creative behavior. We use all the right buzzwords, right? But we're teaching non-creative behavior. And in fact, we're probably in a more connected time in life than any time prior, right? We would even say that we're hyper-connected in the world we're in right now. And I learned about this, not that long ago, because I've seen the future. My 11-year-old daughter said, we have to go see this pop sensation, Ariana Grande. So here we are watching this, and those lights are cell phones. They're all just cell phones. And you're struck by this young generation is growing up in a way very differently than I grew up. And I don't know if it's better or worse, but I can certainly, it's definitely very different. So how are we going to prepare this generation to be able to do the things that we need them to do? And here's the other thing that's very, very, very scary. Research suggests that creativity scores on the same test taken by children and adults have very different results. In fact, it's almost like we squeeze the creativity out of ourselves. And you can think about it through our training and where we are, right? If you're in the research side of things, right, everything's a process, right? The scientific method is a process. You're not to deviate from the scientific method. If you're in a surgical subspecialty, here is the way we do the procedure, right? And you have to do it this way because there are consequences to not. So, we're rooting people into this belief that, well, you can't be too creative. And in fact, if you're thinking this way, that's a problem. We need to get you back inside. But here's the point. When you look at other Nobel laureates, when you ask them, and then after they've won, they say, well, what did you do? Like, how did you get to this process? Well, I just keep playing the way I used to play when I was a kid. They use that kind of, joyous wonder of, there's all these really opportunities I'm going to go at. Now, to us, we say, well, you're not focused. You got to stay focused. In the academic environment, what would happen to this type of individual? Right? They would be going around at the age of 30, let's say. They've come in, they've been in the program for 5 years, and they'd say, you're writing all these studies, but they're all over the place. Where's your focus? You need to focus, because if you focus, that's where you're going to become, super successful. And then you have the Nobel laureates who come back and say, you should find those individuals who have wonder in all these different things and allow them to move forward. Give them the funding, because they're the ones that are going to be able to use these, hopefully, multiple things they're doing and bring it all in. But I would ask you this. If you think truthfully about the things you used to do versus the things you're doing now, I look at myself, and I made this list, we're probably none of us are living up to our creative potential. Think of how many times you said, I used to love doing that, and I stopped. Well, why? Because I prioritized my work, which is fine. But what if that stuff is critical to your work? And here's the point. Well, you can have all kinds of ideas, right? In research, in practice, in medicine, in healthcare, in universities, well, great. Everyone has ideas. But to be truly creative, you have to do something. You have to act on those ideas. So being imaginative, we can all have an imagination. That's wonderful. But to be creative, you actually have to act and do something. So this is what we've been doing. And I'll share with you some of the things that I've been doing, simply not in any way to tell you. The last 4 months, I have almost taken a hiatus away from all the things that I used to think were really important in terms of getting better in the work I do, which is orthopedics and research and reinvesting. Now, it may seem like it's all I'm doing is all these activities and hobbies. It's not so much that, but I am making a real focused effort to learn and go back. So, for example, we have started at McMaster to have workshops on creativity. And people say, well, what does that mean? It means we have to start thinking about what it means to be creative and ultimately what it means to move forward in this direction. And where do you get your ideas? We always say, you get these brilliant ideas in the shower. And then some people would say, there are individuals who actually have water boards in their shower with marker, and they make notes. And they do it because you think, well, that sounds crazy. But there's actually been data that suggested that we get ideas. And I suspect, based on that estimate, 3 or 4 of you have had a really brilliant idea while taking a shower, right? And in fact, some of you probably only take a shower because you need to clear your head and get an idea, right? There's people who do that. So it's not completely crazy to think, well, that this concept, but really what are you doing? You're just distracting yourself. You're just getting up, moving around. You're in a place here where after a while they get up, you go for a coffee, you go for a walk, you meet someone. You're just trying to clear your head. You're distracting yourself from that. What we've started doing is getting out of the office, period. So this is our leadership team for, these are our 3 program coordinators for some of our big trials, and we just walk and talk. That's it. And we call it virtual office. It was taken with a ton of resistance early on, and now it's just become part of the thing we do. Just get out and get around. When's the last time you've just organized a breakfast with individuals which you have absolutely no prior relationship and simply are meeting for the first time? And try that phone call. So these are all individuals at McMaster University, and I sent emails out and I said, there's a marketing professor at the university and a behavioral neuroscientist. They're at McMaster. I just called up and said, I'd like to take you out for breakfast. The amount of awkwardness on the phone when some random stranger like to take you out for breakfast, you just see it. Like you think I'm going to do something to them. And so basically it was I'd like to take you out for breakfast. They go, well, why? Would you use an agenda? Do you need something? No. Take you out for breakfast. Oh, we'll cover. You're going to pay? Okay. Do I need to do something? No. No, just come for breakfast. He goes, well, what's the agenda? Like, what do we talk about? Oh, I don't know, just take it for breakfast, we'll see. And is there no deliverable? There's no deliverable from this meeting, just, we're at McMaster. So they reluctantly came. This was probably 15 minutes afterwards into it, and everyone had a commonality. And the fundamental concept, and we see it in the business literature all the time, if you take people from different backgrounds, you put them together, you realize you're more alike than you are different. And in fact, our work plan turned out that there's a lot of interesting ideas and viewpoints on the same problem. So we just said, here's a problem I'm having. Have a neuroscientist approach the problem you're having from his perspective, a dean of nursing from the education, her perspective, and a marketing professor in business from his perspective. You have a whole different approach to thinking about that problem because you've been fundamentally triangulating with different people. So this has become a classic program now in our division because we just do it. And we just say, I put out a budget as part of our division head, and say, we have X dollars. Anybody who wants to have a, quote, breakfast breakthrough, just identify 4 people. Caveat, you can't know them. They can't just be your friends having breakfast. You have to people you don't know, organize it, and we'll fund it for you. And go and do it. And we're seeing more and more people uptake that. I love biking, so I said, I'll get out there. And one of my more than the New England Journal paper that I was very honored to have, getting published in a mountain biking journal was a new high for me. And this happened about 6 months ago. So completely different. Right? Getting out there and taking pictures and having fun, completely exhilarating. I had the opportunity a week ago, I was in Cambridge, and I said, I'm just going to call up the small little boutique restaurant who has a, really, on social media, they're always talking about, the chef's always coming out and talking to people. I said, hey, I have an evening, I'm here in Cambridge, I'm going to be lecturing at the Cambridge University, and he says, come on in. So I sat down. I just come for dinner. And then he goes, no, come on the back. He goes, you want to get ready? I said, what? And then he was letting me just, decorate and do some things. Obviously, it was completely under, supervision because people were eating this food. So I wasn't going to do anything that was going to be, complicated. But just having a moment with a creative chef changes your mindset. And it was completely somewhat on a whim that I decided to do that. But here's the point. This got me back to painting. I used to paint as a child, and I gave it up. So I went back and I watched how he would just, speckle, these beautiful dishes. So I said, you know what, I'm going to do that. And that picture there was exactly motivated by that evening. Because I said, I'm going to use this technique of speckling, and throw it away. So that's going to apply. Now, what does any of this have to do with research? You might say nothing. I'm going to say it has everything to do with it. Because it's now giving me this sense of we can take on bigger things. You can interact with lots of new people. And ultimately, I think some of the biggest things that are going to happen in the next year for the type of things I'm doing are going to be directly related to this last 3 or 4 months of these types of experiences. And I would put forth to you, some of the group here are leaders. And when you think, I'm a student, I'm not a leader, everything's relative. Because every single one of you at any stage is a leader to somebody else. You have the opportunity to lead. So when you think about it, and you think about what we have to be doing, we've got to be investing. We've got to find talent. And how do you find talent? Well, this is in the business world. The CEOs are out there to say, my job is to identify and retain talent, right? And if we identify talent, bring them up as possibly as big as you can. And that's what he did. Jack Welch did. He's called the CEO of the century. Why? He basically said, I was a talent master. HR, human resource. And the other thing that's said here is not everybody is going to be adept to do everything. So for example, not everyone should become an academic researcher. Right? And I've had many, many graduate students who, after defending their PhD, have come and said, I'm really happy for that experience, but I don't see myself moving in this direction. While for me personally, I think, oh my gosh, it's a personal loss. I failed them somehow. The reality is, I would be failing them if I continued to push them to stay in a career path that didn't meet their passion. The cliche word of passion. So our job is to identify individuals, help them identify where they need to go, and then let them go. That's what we need to be doing. And I'll end you with the last few slides here. Anyone here recognize which one here is the Picasso? Now, if you look at, right. So your initial gut is, oh, that's Picasso right there. But actually, they're all Picasso. And people say, well, what's the point of that? Well, the point is, when you are early in your career, and you're thinking, this is not what I expected. I'm stuck in this career path. I don't quite know what to do with it, and I know this doesn't seem right. I just don't feel fulfilled in what I'm doing. Well, that's probably what Picasso would call your blue period. Doesn't mean it doesn't mean that it's still not going to lead to something positive. And then the senior people who say, well, I'm leaving it to the juniors now. Like I'm not going to be able to make any more contributions. I'll leave it to somebody else. The next generation's going to fix all the things because time's done for me. Well, for me, I look at that picture particularly importantly. Picasso's brand and what he did, the impact he made, actually came in the last part of his life. Not in the first part, not in the middle. The impact he had was at the end. And so for all of us, in some degree, and I look at that picture very importantly, thinking, there's lots to be done at any level, at any time. So when we think about getting signal, I still think, though, we should be empowering ourselves with this concept of evidence. However you use it, use data to tell your story, and that's going to help you get signal, right? No matter what you do, whatever vocation in life you have, whatever it is, surgery or not surgery, any job you have, you're going to make decisions with data. If you're a pilot, you're going to make decisions with data, right? You're going to have to, right? There's an element of skill, but there's the whole purpose. And when we talk about how the aviation industry has revolutionized the operating room, why? Because they have checklists and they use data and they use approaches and algorithms really, really well because lives are at stake every single time. And so when things go wrong, they go wrong in a hurry and very, very fast. And you have to have, processes in place. And at the end of the day, whatever that is, when someone says to you, well, we should do something different. Well, yeah, we should do it, but go as big as you possibly can go. So what we do when we're planning a new study, and I'll tell you, when we're thinking about what the next study is, I don't know what the exact next study we're going to do in 2020, we're going to start pitching and planning it, but I will tell you that it is probably going to be the biggest thing we've ever done. Why? Not because we need to, but because we have to. That's it. So we'll set a sample size, and I'll say, well, sample size should be 25,000 patients. And then I'll say, okay, great, let's do 30. Let's do 30,000, whatever we have to do. And they say, well, now are you becoming reckless with sample size? Are you saying, because it's real dollars to get these patients in? And I say, it's more reckless to guess wrong and spend $4 or $5 million and don't get an answer. You got to get the answer. So we're almost invariably going to want to go bigger. And so we set our projects to go as big as we possibly can. And finally, the only way we're going to continue this is to find people and embrace those individuals who are willing to take those risks, are happy in some ways that, that they're going to put themselves in positions where they will fail, and they're going to be comfortable with that and teach them to do that. And when you do that, they're going to be able to make some really, really, really impressive, outputs. I'll leave you with a couple of slides here that says, at the end of the day, if you're a scientist, or wherever your vocation may be, you'll probably realize that, your science is only a very small part of what makes who you are, and the abilities that you have. So why don't we take advantage of that and do something? And I would put forth to you that it's never too late to think bigger. I certainly think of it every single day. And so I would say today, you should start telling your story. Thank you very much.
Can I have a microphone? Thank you very much. Thanks. Now you are the 4th ever CLUE Working Group lecturer,
Wow.
not only Order of Canada. So.
Thank you.
So, floor is open for comments, questions. It must be difficult for a Finnish person to make a question after such a wonderful talk. We are very famous of good askers today. So I hope somebody, go on.
That's cool. I like that.
First of all, thank you very much. I just saw half of it.
At
least half of it was great.
Sorry
question.
to interrupt you. Can you introduce yourself?
Oh, yes.
Thank you.
Tero Alitalo, a student here at Helsinki University.
Great.
And I just thought that when you talked about the breakfast meetings,
Yes.
and I kind of thought about the failure aspect. As a Finn, you kind of go to a social situation thinking about, damn it.
Yeah.
But so is it more like jostling the creativity, or than just like going all in and having this kind of worry about the failure of the whole situation, that you have 3 people and you're just like looking at your foods?
So I can tell you, so 2 things. I think you're absolutely correct in that it depends on the lens you have. So someone looking at it can say, oh, that's a creative approach. It's not really that creative, right? Really what it is, but you're hoping that from that, if it goes well, you'll get some ideas that you didn't have, and that'll make you think from a different perspective. But I can tell you so I showed you the picture after about 15 to 20 minutes in. The first 10 minutes, it was the most awkward, just people just sitting there, and they didn't know, like none of us knew what we're supposed to get out of this. And there's a perception of what do we do now? And so I said, let's order food. We order food, and then, it just opens up. It's amazing that if you just comfortably sit. So, the awkwardness, they say, how long can you comfortably sit in silence before someone asks a question? There's an urge to do something. Just sit. Eventually, someone will break the ice because it gets very uncomfortable to sit in silence, and most people don't feel they can do that. So to your point, yes, if you can weather that storm, which isn't that long, 10 minutes, 15 minutes, it went very, very well. The harder of the 2 things was to actually get someone to physically come and meet you who's never met you before without an agenda. Like the concept of the agenda of, I have 10 minutes, what are we going to talk about? And then, by the way, each and every one of them who had the bailout, which is, they walk in and say, oh, I'm so sorry, I'm going to have to leave in 15 minutes, because they were using that as, we all would. Or they'd have someone call them, the usual get out of a meeting quickly if it's going badly. Everyone stayed. In fact, we stayed. It was meant to be 1 hour. It was 2 hours. And people said, when are we coming next? That was the question. When are we meeting next?
Thank you.
Yeah, thank you. Yeah, there's another question. Yeah, thank you.
Hello, my name is Marianna Vaast, and I'm a student here as well. It's not about creativity, my question so much, it's more about the medical research. I was just happened to be here, and I was wondering, there have been in the news here that you might be able to get healed from knee problems just by the idea of having the surgery. That's what has been in the Helsingin Sanomat, in the news here. And you kind of wonder, I've had 2 knee surgeries, and I was just wondering, the first one was failed, and I was wondering, was that actually kind of like a test to see if this will work on this patient? But I can't imagine that that would be the case. But how do they actually conduct these researches to actually see if you might be able to get better without actually doing the procedure, just by the idea?
So we use knee because you brought up knee surgery. there was well, it would have been now a few decades ago, a very important pivotal study that looked at knee arthritis, in which patients were randomized, so randomly allocated to get what we call the full, they put a camera into the knee, they look around and they clean it out, versus just a cut in the, on the skin and just a little bit of a poke inside and nothing else. And that study suggested that there was no difference between having a poke and having a full surgery at that time. And that led to a lot of discussion around this concept of what we call placebo, which is receiving like a sugar pill, like we do it in clinical trials, do it all the time. If you have a drug trial, you get a placebo. You get a sugar pill, basically, and they say, we're trying to identify that, right? And they're saying, well, if there's better than a placebo, then therefore the treatment actually works. But in surgery, it's a very difficult line, because there are some things that we call placebo in surgery that actually have a therapeutic effect. In other words, if someone puts a camera inside the knee, looks around, and infuses fluid inside the knee, just by doing that, you could look at it as, well, we're doing minimal, or we're actually doing something therapeutic, which is removing all of the, all the chemicals and toxic things that are inflammatory agents that are causing you pain. So you're absolutely correct. I would say it's a gray zone, and I would still believe that in 2019, that as we are evaluating most surgical procedures, that many, many, many more surgical procedures have real benefit than none over, this concept placebo. But you're right, there are definitely some, instances where, we may not benefit the same way. And I think what makes surgery so, and this group and researchers so important, is that we are brave enough to ask those questions to ensure that you're getting the appropriate treatments. And we're, more importantly, brave enough to change practice because we learned from those studies. So yes and no is the answer to your question.
Can you, Larry? Good catch.
I'm Dr. Matti Talonen, abdominal surgeon from Helsinki University Hospital. Thanks so much for the lecture. There have been tries and successes with doing multi-center, even international studies.
Right.
My question for you, you said that you have to find the right people from the other hospitals, but what are the other tips of overcoming the problems? And there are lots of problems.
Yeah,
Centers not recruiting, etc. So
yeah. So I mean, it gets back. Research always begins with one thing. It's not cliche, but it begins with a good question. If I can't compel you on the telephone or on a meeting that the question is worthy of you spending a lot of time and energy, and more importantly, putting patients into the study who are also going to, have some degree of, risk getting involved in certain, treatments, you want to make sure that the question is valid. That's number one, right? Assuming we have that, then you're right, it's about of motivation. The real success in research and the centers in our experience have not always been the biggest centers don't always recruit the most patients. It is the most motivated principal investigators at those centers that lead from top down. So centers in which the local principal investigator of that site is really taking ownership of that program. And the culture around this individual is such that this is important. We want to make sure our patients who come understand that research is important. And actually, more times than not, most patients have been more willing to participate in helping others with having answers because they're struggling with the same answers. And so the goal is to how do we make sure that we explain things in a way that ensures that there's no harm and ultimately we can do more. But from the practical points of view, a motivated principal investigator at a site is probably your most valuable asset. All the other things set aside, if we can't get the principal excited at the site, then he or she will have a difficult time engaging the team, and ultimately the team will have a hard time. Patients are also going to see that no one seems to be interested in this, so why would I spend the energy and time to enroll myself in this? Even if I think it might be interesting, no one else seems to be interested. So it's a top-down effect, I think.
So, so how do you take care of those local principal investigators that they actually remain happy to work with you?
Well, the thing is,
what are the
right. So
practical things that you actually...
Yeah, so, I mean, the reality is research is really, really hard. It is hard, right? So, and it's hard for everyone in it, because to do the multi-center, multinational studies requires, I mean, as I said, a decade-long plan, and in that, everyone has to believe we're going in it for the right reason. So the biggest challenge is being truthful and open and honest about where we're heading and what this all means, and always being transparent right from the beginning about what's involved. So that last study, this PREP-IT program, you're telling people this is not a 2-year study, this is going to be multiple years, and we have to be very, very diligent that we don't give up, recruiting after second year thinking, oh, I'm getting tired. Or if we know that centers are going to get fatigued, we have always what we call a succession planning. So, we'll have centers that'll be kind of coming in and out after they've done what's called their recruitment allocation. So we try to make it so we try to decrease the burden, but the only way you can decrease the burden, more countries, more centers, more surgeons, and you get more patients.
Hi, I'm Taina Nykänen. I'm an abdominal surgeon, and thank you for the very inspiring lecture. I still want to ask about building your network. So the people you're collaborating with from different countries, do you know them in person somehow? Have you met them when you've been working, or?
Right.
And then also, do you have a contact person in each country who kind of works with different institutions in that particular country, or do you have different people in different institutions, and then you,
So those are very, very good questions, and they're good questions in that it depends on the scale. But I will tell you that the first 5 years of my practice at McMaster, so I took my formal assistant professor position at McMaster University in 2003, October-ish or something, and basically, I was under a 50% clinical, 50% academic. The 50% academic, I was gone. I was out of the country, traveling. And it was very, very important to travel to all the sites I felt we would need to have real engagement. And the other challenge was, I'll give an example of India. So I was born in India, but when I went back, there was a real skepticism around, well, you're going to come here and take all these patients, we have all these patients, and then there's a real concern about, are you doing this for you, or are you doing this for us? That was that. And so for me personally, it was so much about, spending time and getting people to know that, who we are trying to do the right thing, and we want to work with you, and we're not here to do anything but make us as equals. That took 5 years, visit after visit after visit. And now we have many cities in India, and many investigators. But it did have, to answer your first question, it completely changes when you're starting out to actually meet the critical people in the critical sites. But if I had to choose how to do it, and you only have a certain amount of time and priority, then you're absolutely right, is to identify who you believe are the real motivated, research-minded to yourself, similar to yourself, who are influencers or will be influencers in the future, because if you're connected with them, they will then be able to, do the same thing. So we've done that, for example, in Spain. We've identified some amazingly motivated principal investigators who themselves have a great deal of respectability in their center, and then they have been able to recruit another 5 or 6 centers, and so we all win. And then we have an annual meeting, and we make sure we engage and thank them for all their effort. So in many ways, the bigger you get, the more you need country level, I would say, support. But at the beginning level, nothing beats meeting someone and sitting down and chatting with them to understand that we're more alike than we're different, which is sort of the point of those photographs, which is we're more alike than we're different. And when they see that, then I think you can make massive advancement quickly.
Hi, I'm Ilkka. I'm a thoracic surgeon here in Helsinki. So my question is about economics, because most of these trials may take up to a decade, and the funding that you can get from state government and everything is maxed out at 3-4 years? And the second part of the question is that which is the price range for a per patient? How much does it cost to randomize and conduct a trial? Because it must be mass effect also, but it's something that intrigues me within that size of trials.
So I would say that, so the first question gets to how do you fund these multinational plans? We started out back in 1998 with having the Canadian government try to fund the majority of the patients of the 1,000 that came into the SPRINT trial. It's not a viable approach because most governments in most countries say, well, we're willing to fund research, but we want it to have benefit to the people of our country because that's where we're getting the money. And so we have now what we've done, as you can imagine, is we will have a central large program, a large simple study. Simple is relative, but try to simplify as much as we can, and we get a lead donor, some country that will lead the donation, or in this case, not a donation, it's a research grant. But you may get your first, let's say, $2 million from one grant. We leverage that to say, well, we need $10 million. So then you'd go to, let's say, the United States and try to do the same, but say we already have 2 million, could we get a little bit of extra money? And then we do that all around the world, and we've done that. So we've had multiple large funding agencies representative to their nation provide funding to help recruit within that nation. And that's been one of the strategies to raise some of the larger amounts we needed to do. And in terms of the actual cost, you're right, there you see, right, $10 million. $14 million for roughly 10,000 patients. So you can see sort of the ratio to do that. And obviously, for us, it's critically important to recruit on time and earlier if at all possible. But the biggest challenge is the longer we are delayed, we delay an answer. We can't move on to another answer to help. But more importantly, we are going through fixed costs that we can't, research coordinator time is a fixed cost. So no matter what, if we're not recruiting, we're still paying those costs. So that's why it becomes even more important to identify those investigators who are willing to work with you and other successful trial groups. So if you're jumping into research trials for the first time, when we started orthopedics, we went with a very, very seasoned trialist because we knew that this Professor Guyot, for example, he would have the ability. Dr. Devereux, McMaster, same thing. They have the ability and the proven track record. So you learn, you apprentice, and then you start your own from there.
So in the beginning, you didn't have millions.
No.
I assume, at least. I know most of us here, we don't have millions.
No.
But we can still do big trials.
Absolutely.
So
I'll give you an example. So, the enormous project, which is 40,000 patients, 35,000 recruited, will be recruited and completed for under $1 million Canadian dollars. So it is possible, but it's about getting engagement and making sure that we're able to do it. And in many ways, making sure that regardless, that we were fairly compensated. So in other words, the majority of the money that we got for that project went out, didn't stay inside. Because we wanted to make sure that at the best, that whatever money we get, we send out to the center so they have, the ability to at least continue to do what they do.
So probably no more questions. Maybe I have. So is the obstacle now more inside ourselves, or is it the system which is kind of pushing us to make quickly these? I'm sure it's both, but what do you see? Where is the big obstacle? What we should kind of. You don't know the Finnish system, but I would guess it's not very different from global systems.
Right. So the biggest. I'll speak to orthopedics, but I suspect that all the other surgical disciplines are very similar in the mindset of the way they approach. We have spent so much time competing within each other in orthopedics. Center A versus Center B, and various brands of various institutions around the world. Everyone wants to say, well, we want to be the lead, and we don't want to have other. And that has been the biggest challenge because while we are quote infighting for our own sorting out ourselves in orthopedics, we're not coming together so we can, as an orthopedic group, compete against all the other big programs. And if we come together, And so my biggest challenge has been convince our colleagues that we should try to work together and not compete within each other. Because if we come together, we can then compete against everyone else, right?
Yeah.
And all the other divisions, all the other specialty areas. And we have to make sure that we demonstrate that. And so we haven't been doing that. So that's our biggest issue.
If I can interrupt, I think this is really our issue also here. People typically, they do in one center, then they should maybe think about, okay, we are just, most of these, even though you are in general surgery, still typically a small, the topic what you're doing. And if you put together all your Scandinavian, European, you can actually get big funding, and then you can do something rather than competing whether Tampere is better than Helsinki.
Right, but the first thing that happens is that the respective principals in the group say, okay, well, how do we allocate, what's the attribution of who's doing what, and ultimately how do we ensure that we have the appropriate branding within our, the authorship, or, how do we know who's done what, and how do we make sure of that? So the biggest challenge is, well, we want to do things as a group, and then within the group, the concept of saying, well, what do you mean we're all equal? Yeah, we're all equal. No. Even within a group, we know that when you do group work, not everyone's equal. Everyone knows who's done the work, and everyone knows, but we still optically say we're a group, because the group is much stronger functionally and much more able to lobby for the group's interests than individuals who are infighting within that group. And I'm not saying there's fighting, I'm using this extreme, but it's not arguing or fighting, it's more just everyone feels that they want to have their own brand. And how do you maintain your individual identity in a program that might have 400 surgeons, I think is the big challenge.
Okay, very good. Hopefully you have enjoyed the 4th CLU Working Group lecture. We will have a next lecture next year. The 5th talker, we don't know him or her yet.
Oh yes.
Thank you very much, Mohit Bhandari, for coming here. Thank you for coming. And you can watch the video maybe a couple of days later on YouTube, where you can see also our earlier talk. So thanks everyone for coming, and thank you. Big applaud for Mohit Bhandari.
Thank you. Thank you very much.
Thanks.
Okay, thank you very much.